morning, and want to thank the organizers, EPO and AIOS, for kindly inviting me to be part of this course. And they gave me this enigmatic topic, diplopia and red eyes, and I asked, well, what do you want me to talk about? So I took the perspective of a resident and said, if I see a patient with diplopia and red eyes, if I don't want to wake up the neuro-ophthalmologist in the middle of the night, although they actually don't really care, and they will wake us up anyway. What would a resident in the 21st century do? And I said, well, they probably ask Google, and Google now will go straight to Gemini, and the smarter ones will have got ChatGPT or Perplexity, so they would ask them. So I said, okay, why don't I ask one of these and say, well, what would they tell a resident at 2 a.m. in the morning? And they started off with this, that they said, well, the mechanisms linking red eye and diplopia will be orbital congestion, venous stasis, extraocular muscle dysfunction, congestion, cranial neuropathies, neurovascular. But it tells you nothing about where you're going to find the where you're going to actually find the lesion, right, of the patient. But we all do know that these are the common conditions that will give you diplopia and some red eye, right? Thyroid eye disease, you've heard it mentioned a couple of times this morning already, is pretty common. And they do have red eye. You heard a brief mention of carotid cavernous fistula, and we'll speak a bit more about that later. There's this entity called cavernous sinus thrombosis, which we all fear to see because it usually means the patient is very sick. Because briefly mention infections and inflammations at the orbital apex, but also don't forget this can happen in the orbit itself. And besides infections, you have a whole host of inflammatory conditions that can give rise to diplopia with a red eye, because if it's an inflammation, well, the eye is going to be red as well. So that will include things like idiopathic orbital inflammation, or what was once known as orbital pseudotumor, any inflammatory orbitopathy such as granulomatosis with polyangiitis, orbital myositis, and the flavor of the last couple of years, IgG4 disease. Thyroid eye disease, and you can see a really nice write-up on this on iWiki, written by our very own Rashmin Gandhi. Rashmi, I attributed it correctly, right? Yeah, he's looking modest over there, right? But if you look at and we know that this comes with autoimmune thyroid disease, but 10% can be euthyroid or hypothyroid, and I put there in red, compressive optic neuropathy. Ambika mentioned it earlier. It's really important in looking at a patient with diplopia and red eye that you don't forget the vision, right? A whole host of tests to be done when you're suspecting thyroid eye disease. Imaging is very important to show the enlarged muscles with sparing of the tendons. And then treatment is with initially, now we have a good number of steroid protocols, high dose steroid protocols. Radiotherapy, I think, is still used fairly frequently. And then we have this new wonderful drug called teprotumumab, which most of us can't afford. And if you do have access to this, don't forget it can bring about hearing loss. Right? And finally, there's orbital decompression. But I really wanted you to have a look at this clinical activity score that you have over there. And you look at the number of things that say redness, right? It's 3, 4, 5, 6, and 7, all have to do with redness of the eye. So a little bit of a proptotic eye with a bit of lid retraction and redness almost should signal to us an active thyroid disease in many circumstances. And really, the limitation of eye movement in terms of the clinical activity score comes in on the follow-up visit. But you are going to see the patient at the first visit, and so this is something that we ought to suspect when we see a patient with red eye, a bit of proptosis, and double vision as well. Okay, this is a unilateral thyroid eye disease. You know that in terms of proptosis, bilateral and unilateral proptosis, thyroid eye disease is probably the first diagnosis you have to think about. You can kind of see that subtle redness, I don't know if it's visible there, on the conjunctiva. It's just very subtly red. Don't forget they also have dry eye, but they also have this redness over there. And so, look at the limitation of movements in a number of different directions. Okay, this is unilateral proptosis with thyroid eye disease and the lid retraction. Now, you say, where's the lid retraction? Well, the inferior lid is retracted, right? And that's actually one of the signs that we sometimes miss, the inferior lid retraction. This is the more common one with superior and inferior lid retraction. And again, look at that that redness, that diffuse redness of the eye. And this is how thyroid eye disease presents. Also notice that where the limitation of movement is primarily in up and out gaze in either eye, so telling you that there is limitation in the direction of the superior rectus, which then points to restriction of the inferior rectus. But you heard this earlier, right? A patient presenting with history of thyroid disease and then vision loss and poor limitation of eye movements. Once you see this, you should really start to think of whether the patient has got thyroid eye disease, and quickly do an imaging and quickly attend to this patient so that they don't lose any more vision. But I wanted to quickly move on to this very busy table here, because I was thinking if I were a resident on call at night and I had a patient with this, well, how am I going to think through all these conditions? Because as you can see, they're all first of all, in terms of their presentation, they all come acutely or subacutely. They're all very similar in that they all have redness of the eye of some sort, and they have limitation of eye movements. Inflammation and infection typically cause pain, right? Typically cause pain. But if you have a look at cavernous sinus thrombosis as the condition that might kill the patient, they're typically sick. They have a fever, they have chemosis, eyes proptose, doesn't move. They may have lost vision at that point. They may be septic, right? And then when you do the imaging, right? When you do the imaging, don't forget to image all the way back to the cavernous sinus so that you can see, and that they will have non-enhancing filling defects in the cavernous sinus. What about inflammation versus infection? Well, not always the easiest to tell, right? Not always the easiest to tell, but look at the history, right? And that's in the bottom row there. Look at the history. If they have a history of recent sinusitis or dental infection, and ask this in the history, think about a possibility of an infection. If they have a history of autoimmune disease, well, you can start thinking about autoimmune disease, and then the imaging will give you some clues. A dacryoadenitis typically found in the context of an inflammation. A mass may also signify that. But in an orbital infection, look at the sinuses as well to see if they are involved. And look at the subperiosteal layer for subperiosteal abscesses. Carotid cavernous fistula should be the one thing that everybody who's ever read a book on ophthalmology will say, corkscrew vessels. But how many of you have seen corkscrew vessels in an otherwise very quiet eye, and the only reason for that corkscrew vessel after you've imaged the patient and worked them up is just dry eye, right? That happens all the time, right? But corkscrew vessels, that's the one that's a dead giveaway. And it comes together on imaging with enlarged superior ophthalmic vein, and when you see the corkscrew vessels, don't forget to order the angiography as well, because that's how they're going to make the diagnosis, right? So some useful questions to ask your patient. Do you hear any funny noises in your ear? Is there any pain? Are you ill with fever, headache? And then look at the vision, look at the pupil, look for proptosis, and then of course look for ptosis as well. So a couple of examples. This shows the vessels on the conjunctiva look a little bit. Yes, there we go. So this is so not a very brilliant corkscrew, isn't it? But it is a corkscrew vessel, and so that is indeed a carotid cavernous fistula. How about this one? This guy is clearly lying down in bed, and you have to pry open one eye. Yeah, so he's thinking, okay, this is a really sick guy. He's got cavernous sinus thrombosis. How about this fellow? And so this is also a cavernous sinus thrombosis, but you can see the source of his infection is the nose, right? Yeah, right. There we go. And this one with one eye red, but the other eye not able to elevate. Possibly a thyroid eye disease on one side, right, which is unable to elevate, but maybe the dominant eye, and therefore the other eye is just down. Why angiography? Because the classification and then the subsequent management for carotid cavernous fistula is really just based on angiography. And I thought some interesting things that we could take away from here is actually the sixth nerve is probably the most common cranial neuropathy in this, but muscle enlargement is also possible, right? And so that may be a restrictive picture. But I'm quite sure we're all quite hesitant to go do a force suction test on a hot eye. The eye looks red and you touch it, you know it's just going to make it redder and everybody's going to be really unhappy. But sometimes you just have to do that force suction test, right? I also wanted to point out that besides the enlarged superior ophthalmic vein, sometimes you also see T2 hyperintensity of that superior ophthalmic vein, and that will give you a clue to this being a carotid cavernous fistula. I wanted to, as come to the end, to just briefly touch on IgG4 disease, because this, you know, it seems to rise to the top of all our suspicions, right? And you can see that in order of involvement, it's the lacrimal gland first, then the orbital fat, then the muscles, but they also might involve the trigeminal nerve, so don't forget test corneal sensation, lids, nasolacrimal duct, and the sclera. We like to do serum IgG4, but remember, it's not the diagnostic criteria for IgG4 disease. You actually need to get tissue showing IgG4, right? And if you can't get in the orbit, maybe the salivary glands will help, but it's also not quite the site of involvement, so it may be just coincidental. So histological diagnosis, histology showing the lymphoplasmacytic infiltrate, and immunohistochemistry, so ask for it, showing the IgG4 plasma cells. Now it's more likely bilateral than the typical idiopathic orbital inflammation. If you have bilateral inflammation, think IgG4 disease. And so, in summary, just a simple thought process for 3 a.m. in the morning when you have a patient who decided to come at that time for diplopia and a red eye. Are there typical features, right? I mean, you looked at those pictures and all of you made the diagnosis straight away. See, so you're all qualified to be the neuro-ophthalmologist. Don't call us at 3 in the morning, right? Some of the features are really obvious. Lid retraction is probably going to be a thyroid eye disease, right? If the patient is pretty sick, you're better off guessing and looking for a cavernous sinus thrombosis or something a bit more serious than that, right? Is it unilateral or bilateral? What does the redness look like? If you have a corkscrew vessel, well, carotid cavernous fistula. Is there proptosis? Some of them do and some of them don't have it. Is there a pattern that suggests a cranial neuropathy? Don't forget, we are ophthalmologists, so what's the vision like? What's the pupil function like? And look in the fundus for any signs of venous congestion that will point us in the way of something vascular. And with that, thank you very much for your attention.
Thank you, Professor Clement, and that was a wonderful